A great pleasure to introduce Dr. Emily Klein, who's going to be our keynote speaker this morning. Dr. Klein is a clinical psychologist with nearly 20 years of experience working with individuals and families in community mental health settings. She's held faculty positions at Boston University and Harvard Medical School, led research studies on early course psychosis, adolescent and young adult mental health, and parent-focused interventions. She's the author of The School of Hard Talks, How to Have Real Conversations with Your Almost Grown Kids, and creator of the School of Hard Talks online. She's published dozens of articles appearing in a range of peer-reviewed scholarly journals, textbooks, and popular magazines, and has spoken with audiences all over the world about mental health and communication. The title of her talk this morning is Pediatric Primary Care and Coordinated Specialty Care, What Can We Learn from Each Other? Emily, come on up.
All right. Thank you so much for having me and letting me come back and talk to you all. It's so good to be here. It's so good to see all of you guys. Truly, I'm just so excited to see all these nice faces. So as Doe said, my talk is called Pediatric Primary Care and Coordinated Specialty Care. What can we learn from each other? I know many of you, we've all worked together. I've been so involved with MapNet, of course, with the RAP team at BMC, with the LEAP study, all of these things over the years. But a year and a half ago, I decided to take a different track, take a break from psychosis work and go to work for the clinic that's 5 minutes from my house where my kids go, which is a pediatric primary care office as their in-house behavioral health specialist. So I'm there 4 days a week. I'm seeing children and young adults all day, every day. And I'm, of course, staying in touch with you all by doing consulting and teaching and all those fun things on the side. So I'm just here to kind of tell you what I've learned. Some of my perspectives have changed, and some of them I think are just deepened and strengthened and more nuanced as a function of sort of seeing the community mental health system from a very different angle. So I'll tell you all about my job. I'm not here today speaking on behalf of like the Children's PPOC or even my organization. I'm just telling you my experience. But my job is to be, as I said, a behavioral health clinician in a pediatric primary care clinic in this model of behavioral health integration, which is becoming pretty popular around Massachusetts. But I don't really have any information about whether people are doing this elsewhere. But in our practice, it's a 7-physician practice. We take care of about 7,500 children. And there's 2 of us, my colleague Charlotte there and myself, who field all of the behavioral health referrals. So the practice is newborns to 22-year-olds. Sometimes they stay till they're 23, 24. And that yields about 400 behavioral health referrals annually. The practice serves a pretty diverse cross-section of families in Boston, but again, different places might serve different population, have different needs. I would not generalize anything I'm saying today to represent what integrated behavioral health does as a whole. And my job is really consultation, assessment, and then triage or brief intervention. I'm not necessarily, I can't see, there's 400 referrals a year, so I can't see everybody forever. But my job is to kind of be that first look to figure out when somebody has a concern about behavior and mental health, what might be going on here, what would be some helpful next steps. Sometimes I'm providing those next steps, or sometimes I'm making a recommendation about who else might provide that step. And unlike in coordinated specialty care, where we work so closely together and we have these team meetings where we talk about every patient, we don't do that in primary care, right? There's 7,500 kids. So it's much more independent work. I'm not running my formulation by somebody every time. We just kind of make a decision and move on. And then I may go find the referring physician or nurse practitioner to have a conversation one-on-one with them, but it's not like a team approach, I would say. My practice is part of the PPOC, which I really can't remember what it stands for. I can never remember. Like, I'm never going to remember. Something about the physicians. Nope, I don't have it. But it's like a external children's hospital network. And the way that it works is that they provide a lot of wonderful resources, and also sort of quality guidance and metrics, and offer training in evidence-based models for the providers. And in turn, they do a lot of our admin, like we use Epic and all these things that are sort of children's oriented. So it's not part of children's, but collectively, the PPOC practices take care of about a quarter of kids in the state for primary care. So that's a lot. And then I know that like BMC has its own behavioral health integration model, and probably many of the other primary care networks do as well. So it's a pretty common model. All right, so why are doctors sending families to me? Well, the most common reason is that the patient asks to see me, right? The parent or the teenager will say, I've been feeling down, I've been feeling depressed, or I'm worried about my kid's behavior, or academics are suddenly a big problem this year, or toilet training was going well and now it's going very badly, or everyone is melting down at bedtime. And the doctors say, great, we have an in-house team that you can talk to. So that's the most common mechanism for somebody kind of rising to my attention, getting on my schedule. Somewhat less common is that there'll be an encounter with one of the physicians or nurse practitioners that's nominally about something else, like an annual well visit or a sick visit, where the doctor ends up asking some questions that lead to a conversation about behavioral health. So I know that all the doctors I work with, especially with the teenagers, are really wonderful in their annual well visits of asking those questions, like, how are things going with your friends? How do you feel about school? And having a conversation about stress management and behavioral health in those well visits. But it will also come up at sick visits. Like, I'm recalling one young man who came in with the flu, and in the course of the visit that was focused on flu, disclosed that he had a recent, totally unobserved, untreated suicide attempt, and then ended up on my calendar for the next day. So that happens too. It's not as common as people advocating for themselves and coming to our attention, but that happens as well. And then the least common is really that one of these screening questionnaires that everybody has to use actually works. They're not that valuable. They don't really tell us very much. That's one of the things I've had to learn in this job, is like that the PSC-17 or the PHQ-4 or whatever, those are the two main sort of universal screening tools that are used with our kids. They don't really tell us much useful information, unless they're identifying someone who is well known to have behavioral concerns. So they're very rarely useful for sort of that first early identification, bringing someone to our attention kind of thing. So that's one of my lessons that I've learned of giving it away right at the beginning. But that's been really interesting to me, actually. So once somebody is on my calendar, what does the consultation look like? So for younger kids, we meet with them and their parents separately. For older kids, we do more of a combined visit, play it by ear. And there's an emphasis on the presenting problem. You know, I'm trying to follow the clinical narrative, get a sense of what's bothering them, why they wanted to see me. It's not like when I worked, you know, for years screening all the patients for like Naples or drug studies, right? And I was going through the whole skid and doing every single module and considering every differential, right? It's a much more quick and to the point process. What brings you in today? And I'm using my own clinical judgment, I think, as we all do, to try and ask the right questions and shape the formulation and the assessment. But I'm really trying by the end of 45 minutes to understand the nature and history of this person's concern, form an initial diagnosis or at least a good differential, and give the family, by the end of the 45 minutes, a menu of next steps. What's going to be helpful for you? So I have to make decisions really quickly. And we see everything. And I do 2 consults a day usually. So it's a lot of traffic and it's a lot of volume and you have to make decisions fast. So what happens after consultation? In trying to form this talk, I came up with sort of 4 categories of the kind of feedback that Charlotte and I give every day to these families. So the first category is like reassurance. Like 5-year-olds throw a lot of tantrums. They just do. They're very challenging. They're difficult, right? And we can reassure families that that is normal. You know, they got to hang in there. Or that, yeah, your 12-year-old doesn't open up and talk to you as much as he used to. But I'm not worried about him. I think he just doesn't want to talk to you. That's normal also. Right? So this is the education and reassurance about typical childhood development pathway. Bucket 2 is a little like maybe a step up, as Margaret always says, that stages, right? So what's the next step up? And I would say this is like education and some guided self-management, but with a plan for follow-up. So I might say, like, oh, here's this great book called The School of Hard Talks. You should read it. And then let me know what you think and if it helps you. Or I might say, like, here's some wonderful resources from Children's Hospital on addressing defiant behaviors through increasing like one-on-one time. Or I might say, you know, have a good it sounds like you need to talk to the teacher, have a good sit down face-to-face, not on Zoom, maybe initiate that IEP process, whatever, right? I'm giving advice, but it's something that they go and do. And then I say, let's follow up in 6 weeks. Let me know how it went. And if this is getting better, worse, the same, we'll figure it out. The next step up is short-term therapy. So, and this is like for kids with anxiety, more mild for initial onset depression, defiant behaviors, sometimes a lot of adjustment issues, you know, death, divorce, all this stuff, some trauma. If I think it's the kind of problem that is going to be responsive to like 4 to 12, we're supposed to limit it to 12, sometimes 16, 20 sessions of therapy with me, we schedule it. I'm like, I can help you with this. I think I can treat this. And we see like how that goes. And if it's getting better, that's great. We can wrap it up. If it is not getting better, you know, by session like 8 or 10, you know, I start to think about like, do we need to refer you to somebody longer term or do a med consult or something like that? And then there's when I say, I know what this is, or I think I know what this is, but I can't treat you here. But let me help you figure out who can help you with this. And this is where I make a referral to an outside provider because I don't have the specialization or I can't offer the type or duration of treatment that I think this person is really going to benefit from. Or there's just an acuity there, I need for a higher level of care, like let me put in a referral to a partial and let's check back in 3 weeks. And this is really the CSC bucket, right? So this is where I'm sending people where I really have a big concern about first episode psychosis. All right, so that's my job, and I'm happy to talk more about it if you guys have any questions. But let's get to the psychosis piece because that's why we're here. So here's some numbers. And again, this is just reviewing my own encounter notes. Like this is not a research study. This is just a 1.5 years of doing work and telling you guys about it. So it's about 400 behavioral health referrals annually. The youngest patient referred to me has been 3 and the oldest 23. And I have seen at least a handful of cases where I had a concern for emergent or new onset psychosis. And I'm going to tell you guys about those cases because there's few enough that I can tell you about them. And I think they're really rich. So I'm not going to tell you, though, about cases where there's some psychotic, like odd, interesting experiences that are more consistent with a clear sort of OCD or panic disorder, because that I definitely see a good number of. And I'm also not going to tell you about the kids. As I said, I'm a first look. So I'm not going to tell you about the kids who are known to have more severe mental health problems and they're plugged into the system, and they may come across my radar, but I don't typically see those kids because they're already plugged in. Like, what am I going to add? Nothing. So I'm not going to talk about those cases either, though they do exist. All right, so this is just looking at my own encounter notes from 6/1/24 to 8/14/25, or 10/14/25 last month. And I had seen 255 unique patients, and most of them were little. Only a third of them are even 13 or up. And a smaller slice of them, 12%, were 18 or up. So I'm seeing mostly little kids, and I think that's pretty typical when I talk to the other behavioral health clinicians in the PPOC practices. We spend a lot of our time on little kids. So we're not seeing a ton of these more adolescent onset, young adult onset problems. I made this slide, actually, one came in under the radar last week, so it's actually 7. Where I've had a concern about a new onset psychosis or attenuated psychosis presentation. So I'm just going to tell you about them. And these are all anonymized with some details changed, but I like to keep the details in because that's what makes it really rich. I learned from Kesh, it's the most interesting part of any talk is always the cases. So I'm going to tell you first about Luca. And I'm telling you these just in the order in which I saw them. So there's no other order than that. There's some cases I feel really good about and really bad about. This one I feel bad about. So this was my first week at work, and I felt really self-conscious because I was the psychosis lady trying to practice in peds, and right away I'm like, this is psychosis. But I was right. But that doesn't matter. Okay, so because it didn't turn out that well. So even when you're right about the diagnosis, it doesn't mean you know what to do. So this is a 15-year-old boy who presented with chief complaint of new onset urinary incontinence, like pretty strange. The PCP made a bunch of referrals, multiple specialists, including me. And so he'd already seen like urology and they had ruled out anything wrong. So now he's on my schedule. The exam was very notable for mass-like affect, total lack of interest in going to school or seeing friends, and just this calm and peaceful presence in my office next to his mom, who was like, "What's wrong with him?" Which was quite odd, right? This is from my note. He doesn't like people knowing about him. About 4 months ago, he developed a belief that he's being monitored by the government. He believes that a black screen indicates surveillance. He won't go into a room with any black screen. Everything has to be on all the time. He also has stopped drinking tap water. He believes it's been tampered with. This is all reported by his mom, who's sitting there in the room. He doesn't deny any, but he goes, "Oh yeah, that's true. That's true." But he doesn't elaborate at all. So what did I do? Well, I sent him to the CBHC for a walk-in, which I thought was a good recommendation. But it didn't go well. They didn't like it. They didn't understand what was supposed to happen there. They went home before being seen, and they wanted to see me again. So I saw them again, and I was like, I really don't think I just want him seen by psychiatry. It doesn't have to be the people I sent you to, but there's lots of different great psychiatrists. Like you can see, these wonderful people at BMC. We can refer you to Children's, wherever. But they were just very distrustful. They only wanted to be seen in primary care. And just a negative attitude around psychiatry medication in general. I know we've all seen this, encountered this. I tried to, I was game. I tried to meet them where they were at. We did a couple sessions of, sort of motivational interviewing, education, and eventually they just fell off. They stopped scheduling with me. And that wasn't great. I did find out a few months later, the nurses grabbed me. They're like, this patient. The mom had called in, in a panic, saying he's agitated. We can't handle him. And they said, go to the ER. And I guess by the time the nurse called her back, it was over. And she's like, oh, he's fine now. And then I did see, he finally was seen in the ED somewhere, and didn't report anything. And they just said, okay, go home and follow up with someone. So it's just like a lot of missed opportunities, not a great outcome here. But hopefully I'll see them again. And, that's the thing, is that we're all still walking around, right? Like, we're all just people living in this world. So maybe I'll go to work this afternoon and he'll be there. I don't know. I'll get another shot. All right. So let me tell you about a different case. This is a 21-year-old man employed, living with family, with a history of chronic anxiety. When I first met him, he'd had a neuropsych evaluation about 6 months prior that had diagnosed anxiety, major depressive disorder, and ADHD. And the PCP, looked at the report and initiated a stimulant. In my initial evaluation with him, I was struck by an incredibly high level of anxiety and also some speech latency that I thought was odd. But then 2 weeks later, before I'd even seen him again, his mom calls and says, "Whoa, like, things are not good." And I saw him that day, and he came in with totally different affect, very odd and incongruent. He had his hood up. His speech was hard to follow. He said he didn't know what was real and what was not real. He said he felt paranoid. He agreed there's really something wrong with my brain. Like, this doesn't feel right. And I sent him to the ED, and they went, and he was admitted for a couple weeks. He didn't like it there. They left against AMA. We got into rap, of course, because they're great, and had a really good engagement with them. But in spite of like all these good prognostic factors, right? Like, he had 0 DUP, duration of untreated psychosis. He got really good engagement with me, got really good engagement with an excellent coordinated specialty care team. Difficult course. Like, he kept following with me. I think he just liked coming in, even though he was seeing CSC. But I was reading one of your guys' notes recently, and it looked like he was doing a little bit better. So fingers crossed. But difficult, really challenging course. But I read that he was working and driving, which is really important to him. Okay. So different, these are all different. Here's another case. This is an 18-year-old man. I really like this one. This was fascinating. New onset panic disorder. And he was having these panic attacks. It was like the summer before college. He goes to college. His 3rd night in his dorm, he has like the mother of all panic attacks. And all of a sudden, nothing's real. And everything is a projection of my own consciousness. And he could not shake it. This went on for 3 days. And then his parents came and picked him up and brought him in to primary care. And he was very interesting to talk to, because he kept asking, "Are you real? Are you real? Is this book real? Is your computer real?" Very anxious, very upset. He also told me that he was a baseball player, and he told me that he was having this experience where he would predict the next play. And it was incredibly upsetting to him. He's like, "I know that can't be real. That's not happening. That's impossible. How is this happening?" He was also down about 15 pounds. So he really wasn't eating. But there were so many strengths that were obvious to me in meeting with him. Like, he was so eager to get back to school. He really wanted to go to school. He really wanted to study. He really wanted to play baseball. And even though he was describing things to me that were quite bizarre in some ways, he was totally linear. Like, he could describe it to me in perfect organization. So I don't know, what would you do? I'll tell you what I did, which was, I said, "Okay, go back to school." And I gave him and his mom, the best I could do with the education in the hour that we had. So I said, "You seem so reassured when I tell you, yes, I'm real. I had oatmeal for breakfast. I have patients after you." If he stops being reassured by that, that's a problem. If you can't follow his speech, that's a problem. And if he doesn't want to play baseball, that's a problem. But otherwise, like, go to school, find the counseling center, and don't smoke weed. And that's what he did. And he did just fine. Symptoms remitted. As far as I've heard, he's fine. He's come back. It's been a year. Yeah. Okay, this is another case. This is a younger child with a history of ADHD. reporting auditory hallucinations, telling him to kill himself. I was struck by just how stressful his life is. His parents, they had been separated for a long time. It was not a new situation, but they lived in very different towns. And so navigating that was just logistically very challenging. And he was also enduring this incredibly long, awful, unpleasant daily, twice a day bus ride with a lot of bullying, bullying about his size, bullying about his personality, just so mean. Just really, it was just hours a day on this bus getting bullied. In my note, I wrote, he hears voices as if through auditory channel outside his head. They say mean, critical things. They tell him to kill himself or walk into traffic. He feels these are not his thoughts. He would never think such things. He doesn't want to die. It's been occurring for 3 years, but it's been a lot more increased over time. Now daily, becoming difficult to ignore, but again, no suicidal intention or plans. And I was also just struck by how depressed and sad he seemed, so sad. So this again is a patient where I was like, I think this kid probably needs more longer term than what I can offer. But the parents were not interested. They were just like, no, you seem great. And I tried to meet with him, but it was logistically so challenging given all of the stuff I just told you about his life was just logistically challenging. So we managed maybe 6 telehealth sessions and then they were kind of lost to follow up. But I did bump into him the other day in the hallway. And the first thing I noticed about him was his much brighter affect. But the second thing I noticed about him was a different school uniform. And it seems like the parents, I talked to him a bit, it seemed like his parents had finally been able to align with each other to switch the school and get rid of this bus ride. And like, he was so much happier. So I know he's still struggling with social difficulties, ADHD, academic difficulties, but it seems like the psychosis has remitted and the depression has largely remitted as well. But he's 13, right? Things develop. I'm still worried about him. All right, this is a good case. This is a 17-year-old girl who she didn't understand that you're supposed to break off like this, right? She ate this. And it was a disaster for her. She had, she estimated, I would estimate at least 100 milligrams that she consumed at one time, never having used any THC in her life before. But it was probably more, to be honest. Like, I think 100 is conservative. So she experienced tachycardia, derealization, intense mood lability, like laughing, crying, panic attacks, like wild, no prior mental health history, auditory hallucinations, and then these preoccupations with being dead, being in the wrong universe, having slipped through the veil. And it lasted, she said, acutely for 3 days, but at a lower intensity for weeks. And her mom did take her to an emergency room, but they sent her home. They medically cleared her and sent her home. But she said it went on for weeks. So by the time I met her, it was like a month or two later. And she reported that she wasn't experiencing those things anymore, but she had moments of wondering what was real and what was not real. And she did have sort of new onset concentration and anxiety that she had not experienced before. And this was like a few months later. This is a kid who was like so high functioning, so high functioning. So we did a very brief therapy, like 4 sessions. And but again, she was already on this trajectory of returning to baseline. And she did so well that she's like, I think I'm good. I want to stop therapy for now. And I said, cool, you know how to get in touch with me. So she returned to her baseline, did very, very well. And then showed up on my schedule again this fall. And I was like, oh, interesting. What's going on with her? And she told me that the whispers and the uncertainty about what's real and what's not real had returned around when she moved into her college dorm for her freshman year. And I also observed like some mood for sure, like some risk taking, some confidence that seemed off baseline. And then again, we saw each other about 4 times and she went back to baseline. Great. She's doing great. So again, she's 18 now, like anything could happen. She's certainly high risk. But when I ask her, you know, what's going on with marijuana? Are you, how much are you smoking these days? What are you eating? She said, I am a walking PSA. She said, I will tell anyone who will listen what happened to me. So thank you, Sarah, out there doing the work. All right. So this is another case, again, very different. This is a 22-year-old who I actually never met, with history of autism, like probably that level 2 autism, more support needs, not meeting young adult milestones. I was pinged by one of the sort of practice standards is that you're following up with patients seen in any emergency department or any admission within, I think, a week. So the nurses always come and we meet maybe once a week. I meet with one of the nurses and we go through who's been seen for any behavioral or psych reason and, try and figure out, is there anything we can add here? So this is one of those cases. He was brought in by EMS and police to an emergency room after throwing rocks at cars. He said he was experiencing command auditory hallucinations and paranoia. They found his mom. He came to the emergency room and reported a pretty sudden shift over the last 3 weeks with day-night reversal, agitation, aggression. He said he's never done any of that stuff before. I looked through the chart, like I scrolled way, way down, and I could see he'd been seen once in an emergency room for psych, but it was for like passive SI and they sent him home. So this was true new onset. And I spoke with the mom and she told me what had happened. I talked to the pediatrician who was like, no, that can't be right. He has autism. But she called the mom and then was like, oh no, he has something new. And so, sent them, of course, to my besties at RAP. And he was seen pretty quickly. So hopefully he'll do well there. But again, difficult case. And then I said 6 cases, but there was actually 7 because this guy came in last week. So this is kind of just a different one. I think it's worth sharing. 15-year-old with no prior mental health history. The mom called the practice frantic, saying, I heard from his dad that he said that he's been hearing voices telling him to die for 3 years. And, the nurse's hair was on fire. Like, what? And I was like, I don't think somebody would have noticed if that was happening for 3 years. But yes, I will see him. And once I met him, it seemed pretty transient. The 3 years thing was really, this had happened like twice, 3 years apart, where he heard a scary voice on waking. I could not elicit any other problems. Like he was like, yeah, math is hard. Sometimes my mom tells me I have to put my, video game away. I get mad, like nothing else, like just normal 15-year-old boy. I'm guessing he's like, well, I'm not going to speculate. Anyway, I offered like reassurance, education. This can happen. I'm not worried about it, but maybe work on like communication, because the mom hadn't even said, is this true? She had brought him right in, right? I was like, that, maybe talk about it next time. So I'll see them again in a couple of weeks. We'll see how he's doing. And then I will say that MCPAP is another resource, and the pediatrician was a bit freaked by this one and called MCPAP just for further consultation. And they agreed with my formulation of just sort of hypnagogic hallucination. All right, so what are the lessons learned? I think one is just, I hope that it's helpful for you guys to understand IBH a little bit deeper and how these cases do and don't arise in that setting. Again, I'm not going to see the kids who are like, the kids like at Riverside. Like those are not the kids I see in IBH, right? The life skills Larry kids. Like those kids are plugged into the system. They may, of course, having like autism or depression doesn't decrease or eliminate your risk for also developing a different disorder. But like, I'm not going to be the one to triage that in the IBH, the integrated behavioral health setting. what we're really looking at is like new problems, like something's new, something's different. But also I think it is, you know, for these cases, I'm glad I was able to help them, right? And I think it's really worth making sure that behavioral health clinicians in these settings do know something about psychosis, how to assess it, and what the resources are. Also, okay, so that's sort of that point. I covered all that. All right. Lesson 2 is really where I have to eat like my own sort of humble pie because I've done so much research on screening, but I have to say it's just not useful in this setting. Like it's barely used, like maybe this useful. Which is not to say I don't use standardized assessments. I do all the time, right? As part of just my data collection. Like I want to benchmark how bad your depression or anxiety is, and see if, you know, because with the volume that I see, I don't really remember, to be honest, like how you looked 6 weeks ago. So I'm going to look at your PHQ-9 from 6 weeks ago. But in terms of identifying new problems, you know, my optimism for that has lowered. Hopefully, you know, I'm not being overly cynical here. I also have had this thought that I just want to throw out that like screening can be quite a paternalistic thing to do, right? Like if you have a good relationship, like patients will tell you what's wrong, right? This idea that you need to shake information out of them like a piggy bank, right, is like kind of silly in some sense. Like they'll tell you if they trust you what's going on. And of course, when resources are scarce, there's this kind of moral, ethical dilemma of, do you identify a problem that then they're going to be aware, oh, I have this problem and there's this specialist who could treat it in 6 months, right? That's like a whole new source of anxiety, right? So I'm not, what you'll notice in my own management, and maybe I'm wrong, I'm always learning, but I have a fairly high bar for referring to specialty care because I don't want people to be upset about like, oh, I can't get in when I'm not 100% sure, yes, you're going to benefit. So just something to think about. Lesson 3 is just the value of relationship, right? Like we're not interchangeable. People have very strong feelings about where they want to get care. And then the lessons for pediatric primary care are that like psychosis does happen. It's emergent. Just because you have something else doesn't mean you won't develop psychosis. So it's important to know what to look for. And I think Empath and Emily Gagan are doing such great work out in the community, educating community mental health centers about what to look for and how to refer, and to develop this knowledge base. This is like an ongoing one. I know people in this room are receptive to the message, but it's a pretty radical message actually in primary care. You know, maybe some caution here. This adult onset or retrospective, oh, it was missed ADHD cases. Like, I'm not sure about that. I think caution is warranted. And then I just want to leave you guys with some great resources. Again, Empath is doing lots of trainings. And also anybody can call them and get a consult on sort of where to go next. And then this is Kristen Woodbury's website that, you know, I and Kelsey and other worked with hers to create years ago, psychosisscreening.org, which has lots of great resources and things to think about for primary care settings. So I've used up all my time. I didn't leave any time for Q&A. I'm sorry, but we can talk, you know, later. Thank you.
A couple of questions from the audience. Don't go.
Hi, I'm with Bride, and I'm a coordinator or performing risk specialist. So because I'm at CHA, we have some interest in a lot of concepts also. We move that for our staff. And I wanted to ask you a little bit about how when a family isn't coming in with the idea that psychosis or psychosuspected symptoms could even be a possibility, how do you introduce that to them without completely deleting them?
Yeah, it's such an important question. Yeah, so when people are coming in and they're not self-identifying psychosis as the presenting concern, what kind of language can you use, like to introduce this and guide them toward the right resource, because it's so stigmatizing and scary. Did I get that right? Okay, good. Yeah, so, I think, again, humility to say, like, I don't, I've seen this before, and sometimes naming the really specific symptom I found is really helpful. Like when you say this is called derealization, people are like, oh, there's a name for that, right? Or, paranoia, or, like thought insertion or something like that, rather than a big umbrella term like psychosis or schizophrenia, can be helpful. And then you kind of, just like anything where you're really trying to show, I hear you as an individual. I'm not trying to fit you right away into some big category. I'm just focused on your experience, right? You're experiencing this thing. And if I'm getting it right, it sounds to me like other patients I've seen, other people have this. It's called this. And then to say, you might benefit from talking with somebody who specializes in that. And it's under this umbrella of, psychosis or whatever. But I don't know, that's just my approach, is to really start with making sure that they feel like you're understanding their very, very specific experience, and reflecting that back, and then working back from that. I mean, I do that with everything, right? Depression, ADHD, anything, where it's like, I'm not just trying to catch you into a category and then set you aside. It's like, okay, so you're having a problem with algebra, right? And you've always had a problem a little bit with spacing out, but this year it's become really acute because you have all these assignments to keep track of and the teacher isn't helping you. And it sounds like, this organizational thing has always been a problem for you. I wonder if it kind of fits into this category. It's not a cure or anything, but I just think people like to be seen as specific, not types. That's not a great answer. But.
There was another hand in the back. Yes, go ahead.
My name is Patrick. I work with Proline. We're trying to work with making people start being more people with feeling illness. My question for you was, we talk about parents a lot, just not wanting to report or going to system that. Why do you think is the reason that parents have this feeling with this? And psychiatry, just don't trust it. Are they worried about what they're not teaching a little bit? Something else? And then secondly, how do you suggest we might deal with if they're believing in something's fault? How do we bring awareness to those people?
So the first question is about that reluctance that some families have to seek treatment in a specialized or psychiatry focused setting, and what that's about. And I think there's just a familiarity and a trust, when you know a place, right? Like if this place has successfully handled every ear infection, every stomach flu, whatever that we've brought to them, I trust that they'll handle this, right? That's just an institutional trust, that I think exists in primary care that doesn't necessarily, anywhere new, right? And then I think also there's a lot of fear about psychiatry and mental health specifically, like that, your kid will be labeled in some way that will set them back or hold them apart from their peers, that they'll be put on a lot of medications, they'll be over medicated. That's a big fear, I think. And also just a real hope, right? Like it represents, I think, a wish on the positive side that we can course correct quickly and easily. Like I wish that for my child, right? I don't want to have to go seek out a whole new diagnosis and treatment setting and get to know all new doctors and therapists. Like can't, you guys were so good with that ear infection. Like, can you guys fix this too? Right. And that is a very understandable wish. Like I would wish that for my child as well. So, they want to exhaust that option maybe first. And then I think there's the other piece that there's a lot of buzz in the culture about the wait list, the expense of psychiatry and therapy. And so people are like, ooh, like they're just anxious thinking about it, right? Like, I don't want to deal with like finding out my kid has some horrible thing and I'm gonna have to pay thousands of dollars out of pocket to manage it. So there's a lot of fear there, I think justifiably. Yeah.
Okay.
Thank you so much for the presentation. My name is I think about when I was younger, 17, 18, 19, first episode of psychosis, and my PCP was I couldn't get into the psychiatrist's office. So after I had discharged from the hospital for 6 months in my PCP, so they had some special visibility to treat my psychosis. And at the time, we were great because we couldn't get the medication any other way.
Yep.
But I have my questions on is a little bit different. It's just like what are you and your colleagues doing to kind of move away from this practice that psychosis and schizophrenia is a black man diagnosis? I'm just curious.
Okay, so first of all, just the comment that PCPs wind up managing prescription regimens for patients with new onset psychosis because sometimes it does take quite a while to find a psychiatrist who can treat, and they hate doing it, but they're doing their best. And then the other question I think is about, what's the role of primary care in trying to make sure that we're not applying diagnostic labels in like a racially discriminatory way? Yeah.
I think for a while, I resonated with that psychosis diagnosis because I know it would like provoke more support, that I would get more support because of it. Now I'm realizing it's so stigmatizing. I'm trying to transition out of it to like more like one and like psychosis, right? And that's just for my own safety because I don't want to get pulled over, like it doesn't matter, right? I'm still a black man behind the seat that has this issue.
Yeah.
So I don't know. I don't know if you can speak to that.
I mean, I think you just said it all better than I could, which is that like there's pros and cons to labeling anything, right? And the pro is that you can marshal some resources. If you use a big word like autism or schizophrenia or psychosis, sometimes you get bumped up the line, right? You get resources other people don't get. But overall, like it's probably not, for a lot of people, feels very dangerous. And I mean, I completely agree with that perspective. Like it's ironic because I do diagnose people with stuff every day. But I'm always telling people like, we can call this adjustment disorder. Like I'm not really intent on labeling things that I am not, if there isn't, like you said, an incredibly clear reason to do so, because I think that stigma is real. And I think that I was just talking about this with the college students in my office the other day. It's been so interesting to be around for long enough to see pendulums swing a couple times, right? So I've been working in community mental health for 20 years. And when I was in grad school, it was all about like reducing stigma, like let's bring stigma down, let's destigmatize conditions. And now I'm cynical and like, obviously there's a strong business case for doing that. But I think it kind of worked, right? Like now you have everybody on TikTok being like, I've had an ADHD all along. But I fear, with everything that Margaret was referring to before, that the pendulum is swinging back and that people who have embraced certain labels may come to regret it. And like, I'm really afraid of that, actually. So I don't have any answers other than I think we can all be cautious about it and not be like just pretending that stigma doesn't exist and it's fine to use these labels. Like, I think they should be used accurately and because like you have to, but with a clear reason in mind. Yeah, complicated though.
Okay, let's take one last question while we have you and we go.
So I'm curious, you focused on your seven cases, but at the beginning you mentioned cases where doctors would or maybe parents would do about kids with like
OCD related symptoms or like soft that goes to sleepover, that kind of thing. I guess I'm curious if you can say anything about how that goes among your colleagues, like among pediatricians who are hearing those things and are then either wondering, is that psychosis? Are they able to kind of, because that's what we hear a lot of back too, is like, you know, cases where we're you hear the details, so like, I'm not concerned about psychosis here, right? But like, they a lot of providers, primary care and also behavioral health through those things and don't have the like nuance always to some of that difference. So
I don't see that. And I think the reason is that, you know, I've done so many SIPSs in my life that like I have it memorized, right? So it's often a part of my kind of, you know, normal encounter, right? So these kids aren't being referred for unusual perceptual experiences. They're being referred for anxiety. Always, always. And then when I sit and talk to them and do my assessment, I elicit some like stuff that's like, oh, huh, okay. But it feels to me in line with, you know, like I'll give you an example. A young woman, college student with, she has I diagnosed her with OCD, and she has this experience every night of this checking behavior, getting out of bed to check to make sure there's no one outside her window with a knife over and over again, right? And it's so intrusive and it's so, but she knows it's not real. And to me, obviously it's unusual, it's very paranoid, but it's to me seemed totally in line with her other symptoms of OCD. So it wasn't the primary care physician saying, she came in talking about someone outside her window. They're saying she seems anxious. What do you think? Yeah.
Great. Thank you very much, Emily, for a great presentation.